Assalamu alaikum. Today we will discuss the last chapter of science of dental materials, the endodontic materials. So, starting endodontic materials. All you people are well aware of RCT. RCT means root canal treatment. So, the materials which are used in RCT, and RCT is an endodontic procedure. Material used in endodontics or in RCTs are endodontic materials. So endodontics in root canal is usually used as root canal treatment, which is RCT. Injured pulp tissue due to trauma or caries is there. So we have to remove the damaged or infected pulp tissues and obturate the root canal, mean to seal the root canal, which we have treated. So this all covers the endodontics. Now, objective is clean and shape up to 0.5 millimeter close to the peri-apex. Peri-apex mean apical area of the tooth, and peri mean surrounding. Obturation should be a three-dimensional obturation of the canal system, which we have treated, and with obturation is with an inert and biocompatible material. Inert mean which should not harm to the surrounding tissue. And the coronal seal, coronal mean this at the crown portion. You people are now well aware of all these terminologies. A coronal seal which prevents ingress of bacteria from your mouth, from the oral cavity to reinfect the root canal system, which we have disinfected and prevented. Now, materials are irrigants and lubricants for canal preparation, maintenance of disinfection of canals. So, for bulk filling, we use gutta percha points, which are also termed as GP points. Sealant for sealing and obturation. Restoration either in the form of crown or in the form of filling. Endodontic surgery and repair of internal damage within the root canal system. So all the materials for these procedures will be discussed one by one. Now, irrigants and lubricants used for flush out the debris from prepared root canals to help to disturb debris in the canal to disinfect the canal. Sorry. Now, properties of an ideal irrigant. According to Walton and Torabinejad in 2002 were described as follows. They must dissolve or disrupt tissue and debris. They must be non-toxic, having low surface tension for maximum penetration. Lubricate instruments in the canal. Instruments mean the files which we are going to use sterilize or at worst disinfect the canal, remove the smeared layer of preparation debris from the canal walls. Now, different irrigants and their capacity and their role of an endodontic as an endodontic irrigant is: number one is saline. Flushing of debris, yes, it can. Softening, removal of tissue from the canal, no. Disinfection of the canal, no. Local anesthetic solution. Flushing of debris, yes. Softening, removal of tissue from the canal, no. Disinfection of the canal, no. Chlorhexidine gluconate. Flushing of debris, yes. Softening, removal of tissue from the canal, no. Disinfection of the canal, yes, because it is a disinfectant. Sodium hypochlorite. Flushing of debris, yes. Softening, removal of tissue from the canal. Sodium hypochlorite is capable of breaking down organic debris within the canal, facilitating cleansing. More effective when the irrigant is used in combination with ultrasonic agitation from an endodontic instrument. These instruments are available having specialized attachment in your ultrasonic scaler. And disinfection of the canal, yes, sodium hypochlorite is a disinfectant. Alternative most effective is the sodium hypochlorite, and it can be used, or it is used at a concentration of between 2% and 10%. Other proprietary solutions are also available. You can also dilute commercially available thin bleach, which is about 5.25% hypochlorite, and it should be diluted in 1:1 with water, which will give you a 2.6% solution. Disadvantage of sodium hypochlorite that it is a tissue irritant and causes ulceration of the oral and esophageal mucosa if allowed into the mouth. Provokes an intense and extremely painful inflammatory response if expressed out of the tooth in the bone around the tooth. You can see this is an hypochlorite accident. Facial swelling, redness. Now, prevention. How to prevent this attack or this accident? Apply rubber dam to isolate the tooth from the oral environment. If not achievable as a consequence of loss of coronal structure or not possible to confine the irrigant within a tooth, hypochlorite should not be used. Chlorhexidine. Where the apex of a tooth has not fully formed at the time of pulp death in young children. Internal damage within the structure of the root resulting in perforation through the side of the root. Perforation through the side of the root means that we are repairing a tooth for a root canal treatment. This is our pulp. We are using our burr. You can consider it as a burr. And we can go there as this will be our I think we will remove this one, and during preparation we can go there like this one. So this is our perforation at this point. You can see this area. So we have perforated the tooth structure below the pulp chamber, and we enter the furcation point of two roots and make a hole through and through. So this is the perforation through the side of the root. So another chance, but leave it, you will study it in your next classes. So this is the perforation to the side of the root. Irrigant could leak. Chlorhexidine gluconate in a 0.2% solution can be used safely at this situation, and it is available commercially as a mouthwash. You have not to worry to buy this solution separately. You can use chlorhexidine mouthwash. Now comes the EDTA. All irrigants lubricate the passage of instruments. Ethylene diamine tetraacetic acid gel considered as a custom lubricant. EDTA also softens the walls of the canals and facilitate the negotiation of canals where internal mineralization of canal exists. Due to the mineralization, internal mineralization, canal will become closed. So you cannot go through that canal. So the EDTA will facilitate to go into that canal. Intra-canal medicaments. Intra-canal medicament is controversial. Little evidence for their benefit unless there are problems with obtaining pulpal anesthesia or attempts of either induce formation of the root apex in young patient apexification, which described previously in previous chapters, or arresting the progress of internal or external root resorption. For internal or external root resorption, you people have to go again for Google and see the pictures. If I have some, I will share with you people. There are three commonly used medicaments. Paramonochlorophenol, which is also PMCP, disinfectant used for reducing recurrent infection between visits. Effectiveness is very short-lived, denatures in the presence of calcium. No clinical indication for its use. Non-setting calcium hydroxide paste. Very high pH of the order of 11. pH is of 11. Mean it is not acidic, it is basic in nature. A potent antimicrobial action and mild tissue irritant. Promote closure of root apex, that is apexogenesis. Apexogenesis is like the apexification in teeth where loss of vitality has occurred before normal growth and development. The rationale for its routine use as a medicament between visits during endodontics is unclear. Can be left within the tooth for long periods when trying to induce apex closure or arrest root resorption. Poly-antimicrobial paste, a proprietary polyantibiotic paste, which is a mixture of corticosteroid, a sulfonamide, and a tetracycline. And this is used during the management of heart pulps. Heart pulps mean nerve tissue is inflamed, less responsive to local anesthetics due to changes in tissue pH. Difficult to control pain during access into the pulp chamber. Produces reduction of pulp inflammation and facilitate access at the next visit, not at the same visit. It is not possible that you have to apply this paste and readily go for the extirpation of the pulp at that very visit or after some time. Next visit mean after 2 or 3 days. Loses its effectiveness after 5 to 7 days. So you can put it at least for 5 days. No benefit gained from leaving it in pulp chamber for longer because maximum period of its effectiveness is 7 days. Now, obturation or sealing. A root canal is a complex three-dimensional space. Objective of contemporary canal preparation is to clean and shape the root canals to remove bacteria and infected debris. Prepare the space to facilitate its obturation. No attempt to try to prepare the space to conform to a notional geometrical form. Obturation materials are usually plastics or in a plastic stage during placement, easy to be molded to the canal form. After completion of the process, easy removal of part of the entire root filling for a repeat endodontic or insertion of a post like we have seen the post or pins in the dentine for filling to facilitate restoration of the tooth. Historically, the material which is used for this purpose is silver, and these were termed as silver points or silver cones with matching taper to the files or reamers which were used to prepare the canal. It was considered that it should be possible to make a smooth tapered preparation of canals to match silver point to be sealed with. Machine preparation is a wrong concept because anatomy of the root canals is much complicated. No seal can be obtained through this. Again, the silver point themselves underwent corrosive breakdown within the canals, which result in the breakdown of the seal. There were two variations to silver point techniques. Point could either be left to fill the whole canal in length Otherwise, it could be weakened during final preparation, or a segment of silver of 5 to 6 millimeter long would be left at the apex, leaving the remainder of our post preparation if required. One disadvantage of this sectional technique that it was very difficult to retrieve the apical fragment. If the endodontic procedure failed, entire procedure to be repeated with the difficulty to retrieve that piece of silver cone. Now, dental amalgam also been used as an orthograde root filling material. Specialized amalgam carriers and pluggers are used. Amalgam carrier we have seen, which is also called as the amalgam gun. If not, we will see it. Designed to allow the material to be carried to the apex and condensed. Obviously, it would not be possible to remove the mercury-rich layer from the surface as we have done in the uh, mercury restorations. This approach was not amenable to retreatment. Retreatment cannot be done with this, and technically it is difficult to execute. Medicated pastes are also available. Two broad groups are based on paraformaldehyde and 2-SPAD and endomethasone. They contain, and iodoform, all placed in the canal in a liquid or paste form. Iodoform paste remains as paste, and paraformaldehyde products set into a hard mass. Antimicrobial activity of paraformaldehyde is of no match. They can destroy any residual bacteria in the canal system. Paraformaldehyde pastes sets hard and difficult to remove. Insertion of a post is also much difficult with paraformaldehyde treated canals. Retreatment of endodontic lesion, if required, is very complex. If material expressed beyond the apex, it is highly toxic to the tissue and causing lingering pain in bone and dysesthesia. Dysesthesia means change sensation, and anesthesia. Anesthesia, you are well aware, it is numbness. Anesthesia of nerve tissue and dysesthesia. This could be a particular problem if material was inadvertently expressed beyond the apex of a molar tooth into the inferior dental nerve canal. Sometime we people can see, or you can see that this is the inferior alveolar nerve canal, and usually the apex of a molar, root apex of the molar teeth are like this. So if this is the case, the apex is there, apex of molars is within the canals. So this will go directly into the main nerve trunk, and as it sets hard, so it is also an irritant, but after setting it also press the nerves, and these changes, dysesthesia and anesthesia will be there. Now, iodoform, it is iodoform R is missing and E is in place of R. Resorbable used in endodontic treatment. Iodoform paste are resorbable and usually used in deciduous teeth and result in an empty canal in the permanent dentition because they can be leaked out. Obturation, contemporary material for obturation of root canal space is a malleable bulk fill material and a thin sealant, which is used is to fill the spaces around the bulk fill material and to refine adaptation of the materials, particularly to the walls of the repaired root canals. Sealants to fill the spaces between increments of the bulk fill material and improve the quality of adaptation of the composite of sealant and bulk fill to the walls of the root canals and help to maintain the seal around the root filling. Ideal properties of a sealant by Grossman et al. You will study the Grossman inshallah when you go into the next classes. So ideal properties are these: tissue tolerance, insoluble in tissue fluids, dimensionally stable during setting, hermetic mean airtight sealing ability, radio opacity, bacteriostatic or bactericidal, good adhesion to the canal wall when set, easy to mix, non-staining, slow setting time, and easily removed if necessary, may need to be soluble in a solvent to facilitate removal. Essentially thin pastes that can be both introduced into the canal system and used to coat the bulk fill material. Setting time should extend over hours, not in minutes, rather than minutes to allow an exacting clinical technique should be adopted to remove this. If we have our GP point which have crossed, so if the sealant is set, we cannot retrieve it. But if sealant have time, the next day patient come to us and we see that our gutta percha point is crossed. So if the cement is not set, we can easily retrieve the gutta percha point to replace it with the other one. Variety of other sealant dental cements are also available. Glass ionomer, zinc oxide, eugenol, and calcium hydroxide cements are also available. Currently available glass ionomer sealants sets too rapidly. They provide a good seal to tooth structure. Modified zinc oxide eugenol cements are widely used, exemplified by Grossman's formulation. And Grossman formulation is powder is zinc oxide 42 parts, stabilite resins 27 part, bismuth subcarbonate 15 part, barium sulfate 15 parts, and 1 part sodium borate. And liquid always eugenol. Exceptionally long setting time, up to 2 months. You can replace your GP points up to 2 months and provides good peripheral seal and retrievable fillings. Calcium hydroxide provide a good short-term seal because it have to be dissolved. There are some concerns about longer term solubility in sustaining the seal. Nowadays, resin-based products are also available for use with GP, mean gutta-percha points. These are based on epoxy resin, consists of powder which is bismuth oxide 60%, hexamethyl methylene tramine 25%, silver 10%, and titanium dioxide 5%. And liquid is epoxy bisphenol resin. It provides a good seal and marked antiseptic. Silver associated with staining of dentine, release of formaldehyde from material after setting, which is toxic. New products release less formaldehydes. Resin and dentine bonding agents are also used for with polyester bulk film material. Polyester bulk film material is also available. These are chemically setting composite resin loading agents used with the self-etching primer to produce a bonded structure in which resin sealants bonds to both root dentine and the polyester bulk fill material. Now the bulk filling material, it provides an inert mass that can be used to fill the large defect of the prepared root canal. Materials be malleable during insertion phase, must be dimensionally stable. Commonly, modified natural rubber gutta-percha GP points or G gutta-percha are used. Polyester resin-based materials are also available with similar handling characteristics to gutta-percha. Now, gutta-percha, most widely used bulk filling material. In its pure form, gutta-percha is derived from latex as an isomer of rubber known as trans-polyisoprene, less elastic and harder than natural rubber. You can see this. Produced in two crystalline forms, alpha and beta. The alpha form is the natural state, mainly used in thermoplastic manipulation techniques. Beta form is produced by cooling alpha material slowly at a rate of about 0.5 degrees centigrade per hour. The beta form is more commonly used with cold packing technique. Ingredients of gutta-percha, which is used in dentistry, are trans-polyisoprene between 19 and 22%, zinc oxide between 60 and 70%, and a variety of other components including coloring agents, resins, waxes, antioxidants, and metallic salts. Metallic salts, all we know, are used for the radio opacity of the material. Presentation of gutta-percha is in the tapered cone, which may or may not be matched to the size of the instruments used to prepare the canal mechanically, or as pellets of material, which are to be loaded into a gun type delivery system. Polyester resins are Resilon, and Resilon is a commercially available material based on a thermoplastic synthetic polyester. Barium sulfate, bismuth chlorate, and bioactive glass added into this, and bioactive glass added for the release of bioactive glass, because they say that bioactive gases starts regenerative effects. Calcium and phosphate ions from its surface. The bioglasses releases from its surface calcium and phosphate ions, and when they expose to body fluids, they stimulates bone growth. Also available in both tapered and pelleted form for use with either cold or thermoplastic filling techniques. Now, materials for root canal repair and periradicular surgery. A variety of materials are there, which include dental amalgam, zinc oxide, eugenol, modified zinc oxide, eugenol paste, and glass ionomer cements. Keep it in mind, ideal is not achievable, so no material approach the ideal. Mineral trioxide aggregate MTA, an excellent material. Nowadays, this comprises tricalcium silicate, dicalcium silicate, tricalcium aluminate, tetracalcium aluminoferrate, ferrite, calcium sulfate, and bismuth oxide. And amazingly, it is chemical identical to Portland cement, which you can use in your house for the construction of buildings, except incorporation of some bismuth oxide, which increases radio opacity and modifies the setting reaction. Now, manufacturing